So, welcome back. So, in this chapter, we're going to dive into one of the topics that I think deals with some of the more common diagnoses that we see in outpatient physical therapy and occupational therapy. So, we're going to be talking about, of course, epicondylitis of the elbow. Lateral epicondylitis of the elbow is otherwise known as tennis elbow, and it affects the extensors of the wrist and the digits. And medial epicondylitis, otherwise known as golfer's elbow, affects the flexors of the wrist and the digits. And realize, of course, through our anatomy, that the origin of the extensor mechanism is on the lateral epicondyle, and the origin of the flexor mechanism is on the medial epicondyle of the humerus. Now, just for quick definition's sake, the word epicondylitis, the last four letters are itis, which is a Latin derivation meaning inflammation of. So epicondylitis is textbook defined as inflammation of one of the epicondyles of the elbow. And this tends to happen when prolonged repetitive forces are placed on the tendons. And in my opinion, this can especially happen when the alignment is not ideal. And this non-ideal alignment can, of course, occur all over the body. And probably a notable and common example of something that's readily comparable in terms of this, I would say, would involve the heel cord tendon at the level of the ankle. So take, for example, if you have an individual that has extremely flat feet. If you were to look at the alignment when the foot is extremely flat, the heel cord tendon is really put in a slightly different relative angular position due to that valgus stress. And that can definitely long-term possibly feed into the development of a tendonitis. So with elbow epicondylitis, the data out there shows that most of these cases will spontaneously resolve within 1 year of occurrence. I think the cases that we see in the clinic do tend to fall into the more chronic recalcitrant scenarios. So that's something to keep in mind. Now, the neat thing about our discussion as it pertains to epicondylitis of the elbow is that in the last 10 years or so, there has been a bit more of recent research done on tendon pathology. And this new information that we're getting gives us a bit of a different understanding and a bit of a different insight in terms of how we treat these conditions. So we're going to try to address that in this chapter. So before we get into the more recent research and the more recent clinical implementation of therapy, etc., we want to talk briefly kind of about the old school definition of what we thought was going on. So we definitely know that the tendons should normally function to absorb energy and to release energy in a spring-like fashion when our joints are moving. And tendons should also be able to stiffen up when there's a sustained loading. So the old school or the traditional understanding of pathology told us that repetitive stress that is not ideal over time will cause an inflammation in the tendon. And thus, its attachment to the epicondyle area of the humerus will also be involved with that inflammation. Now, our old school model tells us if this inflammation is allowed to persist for long periods of time, this progresses to a more chronic condition known as tendinosis, which is characterized by a failed healing and chronic damage to the tendon at the cellular level. So there was a newer classification that was proposed in 2009, which is similar to the old tendinitis and tendinopathy schema, but with some key differences, which we'll discuss. So the newer classification that was proposed in 2009 was referred to as a continuum of disease. And the same overload and or dysfunction that we discussed in the old model, in this model, causes parts of the tendons to go into what is called a reactive phase. And over time, the cellular changes that we're seeing with this reactive phase have the potential to evolve into what we call a degenerative phase. So what we'll do in the next couple slides is talk about each of these phases in depth. So let's talk a bit about the reactive phase. The reactive phase occurs more early on in the process, as we mentioned. And this, of course, is a reaction to the overloading of tendons in a repetitive nature. So during this phase, the tendon in question, it thickens as more cells are added to the extracellular matrix as a response to excessive or abnormal loading. And this is thought to be a protective response to the load stress. So the depressing thing about this whole process is that the cells that are used to help our bodies repair in a normal manner start to lose their size and their efficacy as we age. So once patients age, let's say into their late 30s or early 40s, there is some data out there that shows that the normative reparative cells that work as we sleep, a couple of these are tenocytes and tenoblasts. These cells have actually been shown to lose a significant amount of their physical size and cytoplasm, which when you think about it, it's kind of troubling. This is just saying that as we age, our potential to deal with micro traumas really starts to take a nosedive. So in a nutshell, patients who are 40 and older should always be told to allow for more time to recover after workouts and after other repetitive activities for this reason. So if this process goes on for too long, things advance more towards a degenerative state, or what we call the degenerative phase. So during this degenerative phase, more changes can be seen in the extracellular matrix of the tendon areas. Collagen fibers, if you were to look at them under a microscope, they tend to look more frayed in orientation. Studies have pointed out that there is a larger presence of what they call type 3 collagen, which is thought to be of lower quality than the original collagen that was present in the tendons. There's also evidence of cell death that's interspersed among the degenerative portions of the tendon. One final observation involves ingrowths of neural tissue. So there's actually some observation out there that has been done through research that shows that one of the reasons why pain may become more prevalent is because there's actually ingrowth of nerve endings in neural tissue. This is probably why interventions that we have done in the past that deal with controlling just the pain aspect, they don't tend to work well, and reoccurrence often occurs. So overall, the gist here is that the degenerative phase is a progression, and it looks like it's a pretty bad thing. And one thing that research has come out with in the last decades, what it points to is that tendon that is chronically in that degenerative phase will not repair itself. So this lends more to the idea that we want to try to deal with the tissue that's in the reactive phase rather than the tissue that is fully degenerative. But there's one positive note here that should help us in our treatment. Rarely will the entire cross-sectional area of the tendon in question be lost to the degenerative phase. So if we were to take various tissue samples of cross-sections of tendons from, let's say, 40-year-olds with lateralepicondylitis, we would probably find that certain areas of those tendons would show signs of the degenerative phase, but we would also find that there are other areas that would either be in the reactive phase or even perhaps some areas that are free from any type of changes at all. So we as clinicians can still at least partially target the unaffected portion of the tendon. An article that was authored by Cook, Rio, Perding, and Docking in 2016 uses the analogy of treating the donut and not the donut hole, which is pretty much what I just spoke about there. This is referring to building up the viability and strength of the remaining healthy tendon as a means of getting the elbow in question to be able to handle the demands that are placed on it. So, and just as a side note here that I've included, there's a really good podcast that talks about this idea in depth. It's entitled, I Came for the Tendinopathy, but I Stayed for the Donuts. And it's produced by a clinical athlete, and I totally recommend listening to this. So hopefully the idea of comparing the continuum of the disease versus the old school model gives us a hint as to how we're going to perhaps slightly change how we're dealing with this in terms of treatment. So we do now know that there is some value in building up the strength and the overall health of the extensor tendon that is still viable in our tennis elbow patients or lateralepicondylitis. We are going to go over specific exercises that should help with this, but I tend to take a holistic approach to epicondylitis, and I think it warrants discussing what my typical intervention is, with an emphasis on the timing of it. And hopefully you'll see that the order in which you do things, especially with these cases, is, in my opinion, is very, very important. So firstly, I'm going to go under the assumption that with all of my epicondylitis patients, that there is at least part of the tendons involved that are undergoing the reactive phase that we spoke about at that first phase. So we want to calm down the reactive phase and allow the cells to do the reparative cells to do their job and to kind of calm things down. And of course, we know the reactive phase occurs because of repetitive overloading and or non-ideal mechanics. So therefore, because of that, the first thing that I'm going to do with most of my patients is immobilize the involved wrist. We don't want continual loading of the wrist extensors. We want, like I said, we want those reparative cells to do their jobs. And in my opinion, the best way to do this is just to keep the extensor muscles from loading for a period of time. There are tons of sturdy wrist braces and immobilizing splints out there that are available online and on drugstores. The emphasis here is on sturdy. The wrist, when it's in a brace, should not be able to move in any direction. So we're going to have a quick video demonstration here of wrist brace fitting. And a couple other ideas as well. And we're also going to include with this video a quick demonstration of elbow tendon glides that I tend to prescribe to patients to do daily during the prescribed immobilization phase, just so that they keep things moving. So let's take a look at this. Okay, so to supplement our discussion on epicondylitis and the whole treatment protocol for that, it's mentioned that one thing that I tend to do and other therapists tend to do, which I agree, is getting that initial immobilization period to allow that reactive phase to kind of calm down a bit. And what I've found is that there are tons of different braces for immobilization out there. In my opinion, is that you want to have a wrist brace that really securely puts the wrist into a comfortable position and will not allow a lot of wrist flexion and extension. Remember, we want to keep those wrist flexors and extensors from firing and keep that wrist from moving for that 7 to 14 day period for immobilization. I have found that a lot of braces that people buy that are prefabbed or store-bought allow too much range of motion. So the first thing I'll tell patients to do is make sure you get a wrist brace that securely puts your wrist in place, and try the wrist brace on. Put the brace on and make sure that it feels nice and snug, and it should feel, the word that I use a lot is sturdy. You want a nice sturdy wrist brace. And I found an example of a decent one that I found online. You can get everything on Amazon now, or you can go to a higher end pharmacy, and they usually have some pretty good prefabbed ones. So you can see from this brace here, this has a metal stay in it that's pretty stiff. So this is going to hold the wrist in a pretty decent position. So my hand's going in like so. And you can see that it's going over the wrist line, obviously. It has space for the thumb to move freely. And you want it to go up at least halfway up your forearm. So this almost is
too small for me, but I would say this is adequate. And what we're going to do is strap this into place. And patients can obviously adjust the strapping and cut strapping off later. And the patient should try the brace on at the pharmacy, because if it's not comfortable for them, they're not going to wear it. So you can see now when I'm trying to move my wrist into flexion and extension, I can maybe move it a tiny bit, but this is pretty sturdy. This is going to keep me in place. And I would recommend this type of thing. Exceptions would be if someone's fingers, for example, are highly involved with the extensor mechanism. If you do your resisted tests and that really provokes the symptoms when you're resisting the digits, I will sometimes make an actual custom splint that's that will actually, here's one right here that I made. And what this does, this is a long splint. So if someone's ECRL and ECRB were involved, we'd have something that would immobilize the wrist. If the ECRL and the ECRB and the digit extensors are also involved, I will at times put the patient in a brace like so, and you can see kind of from the profile of this here. I'm actually going to take their fingers out of this too. I don't want their fingers, working a lot into extension. And this is definitely a pain in the rear for a lot of people to do, because they really lose a lot of functionality of their hand. But in some cases, I really think it's necessary if those digits are involved. So I have just taken the Orfit plastic, made a trace out for my hand. I allowed room for the thumb to be free. And I have made, this is probably one of the definitely more restrictive braces that I will not make every day, but I will make this occasionally to keep someone's fingers from activating and to really try to get that reactive phase to calm down. So in summary, when the wrist flexors or wrist extensors are involved, get a nice sturdy brace. Prefab braces are usually fine. If the fingers are involved, you might have to actually take that extra step and immobilize the wrist and the digits. Now, in terms of brace wearing, I mentioned before, hopefully, that you can have them take the wrist brace off several times a day and just do tendon glides. And I've seen different OTs and PTs have different protocols for tendon gliding. I don't think it has to be very specific. You can create your own, but what I basically tell people is get yourself out of the brace at least 2, possibly more times per day, and do a little bit of tendon gliding. And tendon gliding basically is just going to be, you can do combination movements of just kind of rolling the wrist, so you're getting your hand out of that brace. We just want to make sure that they maintain some glide of all these tendons so everything does not become super hypomobile. Rolling the wrist clockwise, rolling the wrist counterclockwise, supination and pronation of the hand, palm down, wrist flexion and extension, palm up, wrist flexion and extension. Having them do that for like a minute, 2 minutes, just enough to kind of loosen things out and then get them back in the brace. And then once that immobilization period is over, then that's when we're going to start to introduce the loading along the lines of the other information in the presentation in terms of eccentric and concentric loading of the wrist flexors and extensors.
So in summation, my first course of action is to consider immobilizing the wrist for a selected amount of time. In addition to an early immobilization course of treatment, I will also have a lengthy discussion with the patient with his or her first visit in regards to activities that we might deem causal. The typical culprits with lateral epicondylitis, for example, can usually involve the usage of handheld devices, using a mouse at a desktop computer, incorrect keyboard position, carrying objects, driving, or possibly sport activities. So it's crucially important that the patient understand that certain activities need to be minimized or preferably eliminated, at least for the short term. And this may take some convincing on our side to get these patients on board, but I think this is really crucial, especially in this early phase of treatment. So some strategies that I've suggested in the past have included changing the mouse from the affected side to the unaffected side, using assistive devices to transport heavier objects, such as using a backpack rather than holding groceries in one hand, for example, changing the way that someone grips the steering wheel and assessing if they're grabbing the steering wheel too aggressively or too tightly, and also using voice recognition software or the voice recognition function on phones to replace manually typing text or using a keyboard. These are all examples of lessening repetitive activities. Now, do these changes need to be permanent? Certainly not necessarily, but at least for the short term, to get that reactive phase calmed down, I think this is important. Voice recognition software, by the way, has made huge strides over the past 10 years. The Apple iPhone device, for example, has a small microphone icon at the bottom of the screen that allows for text translations, and I tell my patients that they should most definitely be using that. A final thought here on activity modification. I have spoken with many patients and therapists over the last several years about what the best voice recognition software is for desktops and laptop computers. And the feedback that I've been getting is that the answer is the Dragon 15 software. And I've been told from patients who use it a lot, who have tinkered with it, that you will need Windows, iOS, with preferably Windows 10. There's also a good publication out there called Training Your Dragon, which can train you on everything that you need to know basically about the software. Realize here that these types of systems take a bit of time and a bit of training to master. In the long run, it's definitely worth it. I've seen patients take a huge load off of their forearms and become more time efficient in the process. And just as a disclaimer, I'm not getting paid by either Dragon or Microsoft for this. This is just my qualified opinion on the subject matter. Our next intervention involves retraining of movement dysfunction, and I think this is a facet of treatment for lateral epicondylitis in particular that's very often overlooked in regards to patient education. So we've discussed immobilization to calm the reactive phase of tendon pathology, and we've discussed making necessary changes to lessen repetitive actions involved. But we should also teach our patients how to modify the loading motions so as not to feed into a dysfunctional movement pattern. Let's get a bit more specific on this topic using our example of tennis elbow. With lateral epicondylitis, recall that the principal muscles that tend to be involved with this are the extensor carpi radialis longus and the extensor carpi radialis brevis. In the book Movement System Impairment Syndromes, written by Dr. Shirley Sarman and Associates, Dr. Sarman notes that wrist extension combined with forearm pronation overuses the extensor carpi radialis longus and brevis, and it underuses the biceps and the supinator muscles. She also notes that the primary focus of treatment is to decrease the stresses imposed on the wrist extensors by modifying the patient's preferred movement pattern during the functional activities that they perform repeatedly. That's definitely a mouthful, but it's extremely important. So what we're going to talk about in the next couple slides are what do some of these movement patterns look like, and what can we do to lessen the stress and to change them. Take a look at this individual's forearm and wrist position with the following two examples. Using a computer with less than ideal positioning, such as what we're seeing here with this laptop, is probably one of the most obvious manifestations of the wrist in extension coupled with pronation. For this reason, it's always a good idea to conduct a cursory ergonomic evaluation of the patient's setup. One thing that we can certainly do is lessen the degree of wrist extension by changing the orientation of the keyboard and cueing the patient to avoid resting his or her wrists on the table while typing. You can see from that photo there that the wrists are cocked into at least a good 20 degrees of extension, and that goes right along with Dr. Sarman's movement dysfunction of wrist extension and pronation. The second photo is an example of precisely how we should not be telling our patients with lateral epicondylitis to be picking up a weighted bag. Note the same basic pronation and wrist extension. Just the other day I had a patient describe to me how he was using his affected arm to move mattresses. As you may guess, he was using the affected hand in a pronated position to hold the top of the mattress, and the unaffected hand in a supinated position to hold the bottom of the mattress as he carried it. So he was imposing a big load on that arm in the precise movement dysfunction that's described in the publication that's mentioned. Take a look at this woman's wrist positioning as she works on the computer. If the keyboard is in an optimal position, the wrist should not really have to go into extension in order for key striking to happen. So whenever possible, I always think it's a good idea to install an adjustable keyboard tray so that you can tinker with these angles. If you look very closely, you can also see that we've removed the foam wrist rest from in front of the keyboard. And in my opinion, these wrist rests that I mentioned have a tendency to place the wrist into extension with typing, which is kind of what we want to be avoiding. So, and also in terms of the mouse, if we want to get rid of the pronated position, there are some products out there that place the wrist into a more neutral position. A pen tablet, for example, allows the patient to drag a pen over a tablet in order to move the screen cursor. Here's a quick and dirty example of what a pen tablet would look like. There's either a pen or some type of stylus mechanism that's held in the patient's hand. Notice that the wrist is in a neutral position. It's not pronated. And this pen can be dragged around the screen, which would correspond to the mouse moving on the desktop screen. And just a simple tap down with the pen would be a click or a double click. And if you go and do a quick search on the web, you will find that these are pretty easy to find and they're not terribly expensive. I hope that you're noticing here that the treatment ideas that we're going through are eclectic and hopefully touching on ideas that you normally would not have solely considered. So next on our list is one aspect of intervention that is probably also overlooked by a lot of us in clinical practice. A mistake that a lot of us make in regard to tackling this problem is that we tend to laser focus entirely down onto the involved joint or the closely surrounding structures, which unto itself is not necessarily a bad thing, but we tend to forget about the alignment of the patient as a whole and what other, quote, big picture, end quote, factors might be contributing to our lateral epicondylitis patients. So what we really need to be asking ourselves as clinicians is, are there any other postural or larger musculoskeletal issues that could be contributory? Let's take a look at a few photos and a case example to make our point. The individual here is right hand dominant. Take a minute to look at the positioning of his scapulae. Hopefully, there are a few things that jump out at you that fall under the category of not ideal alignment, that could contribute, perhaps, to lateral epicondylitis on the right side in his right elbow. So the first thing that I'm noting here is that his right shoulder blade is elevated compared to the left shoulder blade. And since this individual is right-hand dominant, we would not expect this to happen. Clinically speaking, most right-hand dominant people actually have a right-sided shoulder blade that is typically slightly depressed compared to the non-dominant side. This patient did in fact have a marked weakness in his lower trapezium on the right side with a place and hold test. He had a very hard time even just holding a test position. Secondly, it appears that both of the scapulae are resting in an abducted position. And you can see the contours of the scapulae are way out to the side, particularly on the right side. This will, of course, lead to a length adaptive problem with the scapular adductors, namely the middle trapezium, for example. And the lower and middle trapezium for this patient basically were long and weak. Thirdly, take a look at the direction that the palms of his hands are facing. So with ideal alignment, I was taught in PT school that the palms of the hands should be oriented in such a way that they're facing the body. So in this patient's case, both of the palms are facing towards us, or in more of a posterior direction. This usually means one of three things, perhaps. Either the abducted position of the shoulder blades are creating this position. Picture the scapula wrapping around the curved structure of the rib cage. In this case, if we were to physically move the scapula into more of an adducted position or an ideal position, we would actually see the palm alignment normalize. It's also possible that the glenohumeral joint is in a bit of internal rotation in resting position, or the humerus is in an internal rotated position. In these cases, manually placing the scapula into a more ideal alignment would not change the degree to which the palm faces backwards. And our last possibility is perhaps both of these things are playing a role. So what is the big picture here? Because of the positioning of his right shoulder blade, this patient has a predisposition to grab objects with his palm facing down, which places a load on the wrist extensors. According to Dr. Sarman's observations on lateralepicondylitis, the shoulder blade positioning of this patient is probably feeding into the movement dysfunction down the kinetic chain. So what would be a good idea in terms of strength training for this patient? Well, it makes sense here that we would want to work on getting the scapula into a more ideal position. Specifically, we would want to work on the lower trapezium and the middle trapezium in shortened positions. Depending on whether or not the glenohumeral resting position is in internal rotation, we may also want to work on shoulder external rotation strengthening. So now that we've addressed issues 1 through 4, take a second to digest that in the big picture. And we're now going to circle back to the information that we presented at the beginning of this chapter. Recall that the research done on viable tendon versus degenerative tendon and what this means. We know that there is some evidence-based research that suggests that it's worth our time to maximize the health and the strength of the tendon that is still healthy. Recall that there's healthy tendon, there is tendon that's in the reactive phase, and there's tendon that's in the degenerative phase. So remember the saying, treat the donut, not the hole. It means that the final intervention that we should do involves strength training that's done in an intelligent and sound way. But what is the best way to strength train these tendons? Thankfully, we do have some new research and meta-analysis that can help guide us in working on improving healthy tendon viability. In 2015, Baum took a look at previous studies that dealt with tendon strengthening. And the title of his article is Human Tendon Adaptation in Response to Mechanical Loading, a Systematic Review and Meta-Analysis of Exercise Studies on Healthy Adults. So we do know from earlier research done in the late 1990s that training a muscle eccentrically appears to be a sound way of obtaining strength gains. A study done by Alfredson and others came to the conclusion that heavy load eccentric training of the calf muscle provided benefits in treating chronic Achilles tendinosis, which is readily comparable to forearm tendonitis and epicondylitis. Now, in 2015, Bayer and others compared eccentric training to heavy, slow resistance training as a treatment for tendinopathy. He found that both methods are actually a good way to work on optimizing the viable portion of the Achilles tendon. So, and he furtherly goes on to state that the slow resistance training tends to be in line with better patient satisfaction in the earlier portion. And after 12 weeks, But after 1 year, the satisfaction levels are about the same in both groups. So what does this basically mean? This means that eccentric is a decent way of training, and full range training, concentric, eccentric with heavy loads is a good way of training. So my advice to clinicians would be see what the patient can tolerate and what the patient is into doing, and that is probably a good way to progress with things. So what can we gather from this? It's probably a good idea to introduce tendon strength training to the wrist extensors, but as I mentioned before, the timing of this may be important. Personally, I will work on steps 1 through 4 in our little progression first, prior to introducing wrist extensor training. I can count on one hand in the last 5 years the number of times I've started an epicondylitis patient on either wrist extensor or flexor training right off the bat. Usually I'm waiting a while until the immobilization phase is over and our other steps have gone through. If a patient has an appreciable amount of pain and is demonstrating a lot of the reactive phase that we talked about, in my opinion, I would just immobilize the wrist and let the body's reparative cells do their job for a while first. And like I mentioned, also we want to, of course, train the patient in avoidance of certain activities and modification of lifting, etc. In regard to the type of training that we introduced, you could reasonably make a case for either using the eccentric training or the heavy loading training that's concentric and eccentric. Like I said before, assess the patient's tolerance to the positioning and the exercises. The third point on this slide is very, very important. We most definitely need to temper the patient's expectations about the amount of time that is needed to see demonstrable changes in tendon strength. Most of the research out there points to the notion that we're going to need a minimum of 6 weeks of compliance in order to even see some positive results. So keep that in mind. And as we start to wrap this chapter up, we want to hit a few more topics that you might be wondering how their importance plays into this. One question, of course, is how much pain during the exercise is acceptable. And this has to do more with the step 5 in our treatment regimen. When we introduce strength training in the extensor tendons, how much pain can we reasonably expect? There are slightly differing opinions to this. Most clinicians, myself included, think that at least some pain during exercise in these cases is to be expected. Dr. Sarman, in her publication that I mentioned before, writes that pain should be no greater than 2 out of 10 on a self-reported pain scale and should resolve within 30 to 60 minutes. Aside from pathological type pain, delayed onset muscle soreness type pain the day after would mean that the muscle has recruited well and it's remodeling, and this is probably a good thing. As a final note on strength training, let's not forget about the recovery stage that has to occur in between workouts. I see way too many physical therapists that assign strength training exercises to be done every day. I just don't think that this is a good practice, given what we know about research that has been done on recovery time from workouts. As far back as 1988, there's compelling research that's been done showing that when subjects are subjected to 70 repetitions of maximal contractions of an exercise, 5 days or more of rest is needed for a full recovery. Now, most of us are not having our patients do 70 repetitions of a maximally resisted exercise, but I think that it's a good rule of thumb to allow 48 hours of rest following 3 sets of 15 reps of a moderately loaded exercise, something that's going to fatigue the patient at least moderately. This equates with having the tendon loading exercises done every other day. Do not have your patients do these exercises every day. With patients who are over 40 years of age and beyond that, remember what we said about the tenoblasts and the tenocytes and the decreased viability of these cells. I will often tell older patients to give themselves 3 days of rest rather than 2 days of rest. And as a final thought for this chapter, there are other means of treating lateral epicondylitis that we have not addressed here. Anecdotally, I can say that over the years I have come across some techniques that appear to help certain patients in their treatment process. We're all familiar with the concept of trigger points that exist in muscles, and if a tendon is irritated, you can usually rest assured that the muscle fiber orientation is also going to be a bit messed up. Dry needling is a way of releasing trigger points, which may be helpful in enabling the strengthening process in the long term. I've also seen patients who have immediately benefited from having the epicondyle irritated by an injection from an orthopedist. Current research suggests that steroid injections probably are not helping with epicondylitis because of the lack of a synovial membrane in the involved muscles. But some argue that the physical irritation of the tendons and the bone by the needle somehow reboots the healing process. So that's something also to consider. There are also those of us who practice manual therapy who point out that epicondylitis at times is fed into by a referral pattern of pain from adjacent muscles. It might be worth your time to check out the supinator muscle, the brachialis, the triceps, for example, to see if there are any tender or trigger points in these muscles that you can work out and see if it has a positive effect on your other treatment strategies. And lastly, in the last several years, physicians have also started using PRP, or plasma-rich protein injections, into the epicondyle. And they're starting to have some research that's coming out that's talking about whether that's effective in terms of rebooting the healing process as well. To summarize our thoughts here on the last slide about treating lateral epicondylitis, let's remember the following. There's evidence-based research that can point us in the right direction in regards to optimizing the function of the healthy tendon that remains. Recall that the degenerative portions of the tendon are really not what we're focusing on. Let's also not forget to address the repetitive activity that's causal. To use a descriptive comparison here that brings a little bit of humor, let's say that a patient walks into your office complaining of a headache, and the patient demands to be prescribed painkillers, even though one of the patient's favorite activities or pastimes is striking himself in the head with a hammer. I think that perhaps activity modification would be a better means of addressing this problem rather than using prescribed medication or giving the patient a helmet. Maybe a helmet too would help, if we could not convince the patient to stop hitting themselves in the head. Let's also remember to look up the kinetic chain to see if scapular positioning is lending to a movement pattern dysfunction. And finally, I do think that your judgment as a clinician is key in figuring out when it is the appropriate time to introduce the tendon loading and strengthening phase. In my opinion, it's, like I said before, it's not always prudent to start with tendon loading right off the bat. Your time might be better spent with the other interventions that we spoke about in the chapter to get the ship pointing in the right direction.